Good afternoon, everyone. We're going to get started. We have a lot of good information to share with you. And so we want to start right away so we have enough time for the presentation and for questions. I'm Marjorie Rallins, Executive Director for the Health Data Standards Unit here at Regenstrief. And we're very excited to deliver the first Regenstrief Education and Insights Learning Series for 2024, Health Data Standards, Orientations, and Insights. Joining me today are my colleagues, Stan Huff, who co-chairs the Loink Clinical Committee and is a member of the UCOM Committee, Stephen Wagers, who's the Associate Director for Technical Services and Operations in the Health Data Standards Unit, Tim Briscoe, Systems Engineer 4, and Isa Hafiza, who is the Director of Terminology Services and Operations for our unit. Also here today are our other colleagues, April Lackey and Jennifer Bianchi and Virginia Reel, who will provide color commentary when we get to the Q&A section. There are two parts to our talk today. We'll begin with an orientation and talk about the mission and vision and focus and purpose of the unit. We'll review some historical perspectives and also present some interesting facts. And finally, in this section, we want to redirect some perceptions about the unit overall. It's important to note that, did I do this right, April? I'm good. Okay. It's important to note that the unit is often referred to and sometimes fondly referred to as Loink. And while Loink is a huge focus of what we do, it's important to healthcare. It contributes significantly to Regenstrief's reputation for strength in informatics and contributes to Regenstrief's legacy. A reference to the unit as Loink can be limiting and may not necessarily convey the full scope and purpose of the unit, and may not necessarily convey the value of the unit in terms of Regenstrief, in terms of advancing the mission, vision, goals, et cetera. Today, we hope to clarify that. And in the second part of the presentation, we want to share some highlights of our work, talk about our collaborations, some of our tools and resources, and take a brief look into some of our projects. Together, the orientation, as well as a review of the highlights of our work, should provide some insight into who we are and what we do, and hopefully you have a better understanding overall of the value of our work to Regenstrief and the healthcare community that may not be as apparent to others as it is to us. Okay. Beginning with the mission and vision, they are both clearly stated here and have been in place for quite some time. We have a mission to influence science and policy in an effort to promote health information exchange and interoperability. And our vision is we see a world where systems get clinicians the information they need at the right place and at the right time. Moving on to the focus and purpose, these 4 bullet points summarize the focus and purpose of the Health Data Standards Unit here at Regenstrief. We serve as an authoritative focal point for data standards initiatives and policies across Regenstrief. We work to influence and advocate health data science, and policy across the healthcare community. We have stewardship responsibilities for Loink and UCOM, and many of you are aware of that. And finally, the Data Standards Unit serves as a partner across Regenstrief, aligning key mission and strategic goals. So expanding on these 4 points further And starting with the first one, serving as the authoritative focal point for data standards initiatives and policy means we assure that Regenstrief data standards related activities are fully and effectively integrated. We provide thought leadership and coordination for the development and implementation of a cohesive and Regenstrief-wide approach to promoting data standards. And we coordinate data standards activities with outside organizations. Drilling down a bit more, we are a finely tuned collection of formally trained and nationally and internationally recognized informaticists, clinical terminology developers, software and systems engineers, operational experts, and exceptionally committed volunteers, and we'll talk about that later. We work on the representation of clinical information so that it is standardized, and we accomplish this through our work with LOINC, our work with UCOM, and working with other important national standards as noted here. And we do this work so that clinical information can be used and exchanged electronically with the ultimate goal of helping clinicians deliver safe and effective patient-centered care. To give you a more practical example of being an authoritative focal point, you may be familiar with the generous support that we received from the foundation to work on social determinants of health so that social data that is not always readily available or readily usable in patient records can be standardized and integrated into patient care. This Health Data Standards Work project just reflects one component of Regenstrief's overall effort to address health inequities. A key component for any organization that engages in data standards work is ensuring that the current science and policy supports the needs of your standards and its users. So in our case, it's ensuring that current science and policy support the needs and users of LOINC and UCOM, and conversely, that our work related to the oversight and maintenance of the standard is aligned with current science and policy. These two efforts are tightly coupled and represent about 50% of our unit's work. And that means having active engagement in the areas of healthcare where science and policy are happening, such as the federal initiatives and working with standards development organizations, as well as working with the private and international sector. Here are some examples of where we are contributing, influencing, and advocating through thought leadership and active engagement. Our team members and our committee volunteers are the senior leadership of the U.S. healthcare standards development community, as are many of you that are here today. We serve and often share boards and panels, and sometimes we provide the expert testimony for federal initiatives and provide thought leadership in a variety of ways. Most of you are familiar with our work with LOINC, and some of you are familiar with our work with UCOM. Both are data standards. And I'm going to discuss LOINC and UCOM in slightly more detail on a few slides later when we get to the historical perspective section. The take-home message for this slide is that it takes a variety of expertise to responsibly steward LOINC and UCOM. And the work goes, sort of far beyond developing terms and codes, which is important, but it takes much more than that. It takes terminologists, whether they are professional staff, investigators, or consultants that understand LOINC and UCOM, and it's critical that they have a thorough understanding and demonstrated experience with the design and function of other terminologies, such as those that are listed here. They must understand terminology mapping, and it's critical to have a good understanding of knowledge representation. Stewardship for LOINC and UCOM also requires a strong software engineering and technical department that have extensive experience to support the tools and processes for terminology maintenance and development. Knowledge management and change management expertise is also critical. And as I mentioned on the previous slide, stewardship for any organization that has oversight for terminology requires close collaboration with other standards and standards development organizations. And although I mentioned it on a previous slide, I cannot emphasize enough the importance of collaboration, and you'll hear about some of that later. This point in the focus and purpose section may be listed last, but it is critically important. Health Data Standards is a partner across Regenstrief, aligning key mission and strategic business goals. And what this means is that we contribute to Regenstrief's portfolio of work, either leading or collaborating with other centers, programs, and units, and supporting the strategic initiatives of the organization overall. We recognize that this aspect of our work may not necessarily be apparent. And because of that, we've made this a top level goal in our strategic plan that was updated in 2023. And we've called it out here in the graphic taken from our strategic plan. Fine. And then zeroing in further on this goal, we're beginning to see traction here. Okay, so through what we describe as a bottom-up, top-down, grassroots approach, and by connecting with all of you, our colleagues, and other centers, programs, and units. For example, we're working with GHI on an R01 grant with Johns Hopkins University on computational LOINC. We've worked with RDS and others on the Odyssey and OMOP project. We've responded to at least 6 RFPs, maybe more, with other units, centers, and programs, whether we are either leading or supporting. And recently, we've had inquiries to potentially work together with others, such as IUCAR, CBMI, sorry, and investigators from the IU School of Public Health and more. And some of the topic areas for collaboration are the Public Health Data Modernization Implementation Project, sponsored by the Association of State and Territorial Health Agencies. Another is CDC's National Health Information Network Modernization Project. Another is the Common Data Element Alzheimer's Project. And we've been asked about supporting some work on using health informatics to impact climate change. I think that's very interesting. As you can see, the projects spanned a very broad spectrum of topic areas. Again, the take-home message is that we are here to partner and support the mission and vision, or more, and strategic goals of Regenstrief. So moving on to historical perspectives, here I'd like to briefly share some historical perspectives for context. Our unit Health Data Standards has been associated with Regenstrief since the mid-90s because Clem McDonald and other, then Regenstrief researcher, and other pioneering trailblazers like Stan Huff, who is joining us here today, had a vision for information technology to help clinicians make better decisions in caring for their patients. And this vision would be realized by creating a universal language to describe clinical observations, which we all know is LOINC, logical observations, identifiers, names, and codes. By the late 90s, Dr. McDonald and another researcher, Regenstrief researcher, Gunther Shadow, created a standard called UCOM, or the Unified Code for Units of Measures, to facilitate the electronic communication of measurements in units. LOINC and UCOM are major areas of focus for us, and each has been named in federal regulations and federal initiatives, is mandated for use internationally in a number of countries, which represents the fruits of our labor. In the early days, our primary focus was on developing and refining the standard by primarily term and code development. However, as time, evolved, the development and maintenance of both UCOM and LOINC required and demanded much more of us, including building tools and software and expanding collaboration and engagement with others. We understood that we needed to evolve. And as a unit, we did that. And in doing so, we reached widespread adoption. But I'm not so sure that we advertised or made others aware of the evolution of our work, and particularly our Regenstrief colleagues. And hopefully today, you have a better sense of that. So let's move on to interesting facts. The first interesting fact is that the unit has used at least 3 names over the years. Okay, so LOINC, as many of you know us, was used first and is still in use today. However, we consider it shorthand or nickname. As I mentioned before, it's limited in reflecting who we are and what we do. At some point, we began using LOINC and Health Data Standards, or LHDS, to reflect the broader scope of our work and role. And now, our preferred name, in sort of an informatics language, is Health Data Standards. Is that right, April? Yes. And what is really interesting is that Health Data Standards, as a unit name, was already in existence when I joined Regenstrief. And it was already in existence on the Regenstrief website prior to my tenure in January of 2021. And it's hard to believe that I've been here for 3 years. I think with the extended transition and leadership for the unit name wasn't implemented or in place as intended. Okay, so I forgot to hit the next button. Okay. By using Health Data Standards as our unit name, we're not rebranding ourselves. Instead, we're simply using the name that reflects who we are and what we do. Okay, next. So another interesting fact is that the Health Data Standards Unit is really an extended community. And this is one thing that makes us unique and that we're very proud of. We have the Regenstrief team that is comprised of the professional staff, and the team has the capacity and the capability to include faculty investigators as we need to. We also have an extensive cadre of stakeholders and committed volunteers who help to maintain and develop LOINC and UCOM. It really does take a village to carry out data standards work. We have 5 LOINC committees and a UCOM committee. The co-chairs and advisors are pictured here. We have an exceptionally vibrant international user community who also actively participate in our data standards, in our standards development, our advocacy, and our collaborative efforts. Um, Before moving on to the project initiatives section of the presentation, it's important that we redirect a perception about the unit, whether the unit is called LOINC in Health Data Standards, Health Data Standards. The unit has been organizationally depicted as a service unit, and given the focus and purpose and the scope of our work that we just reviewed, we would describe ourselves very differently and wouldn't use that term service unit. Other nouns that have been used to describe the unit are program, and we believe it doesn't quite right fit, but because it underrepresents the impact of the work, preferably we would describe the unit as the Center for Health Data Standards, but because the term center is used by other and we propose that term because the term center is used by other organizations that describe their units that do analogous work as the Health Data Standards Unit here at Regenstrief. However, because of our academic affiliation, the term center and association with Health Data Standards here is not in alignment with an academic definition. So for now, we wouldn't use that now. We've considered consortium as a potential addition to the unit name to more clearly describe who we are, but more discussion is needed in that area before we proceed with that. So to summarize, the key takeaways in the orientation section, the Health Data Standards Unit is an international leader supporting collaboration across the data standards and healthcare community. We provide thought leadership and influence science and policy and enable research. We serve as a partner across Regenstrief, aligning key mission, strategic, and business goals. We have synergies with Regenstrief centers, programs, and other units to contribute to Regenstrief's portfolio of work. So, in other words, we look forward to working with all of you further. So with that, I'm going to turn it over to, who's up next? Stan Huff, who's going to talk to you about our collaborations.
Thank you, Marjorie. It's a great pleasure to be here. I get lots of fond memories of this room, and I love this environment. It's just great to be here. So I want to talk today about a collaboration that we're doing between Regenstrief and SNOMED International, and with, I guess, specifically with the Health Data Standards Group. This is a great collaboration. Putting it in perspective, for those of you who may not be familiar, SNOMED stands for the Systematized Nomenclature of Medicine, clinical terms. It's a clinical terminology that has diagnosis names, names of body parts and anatomy and organisms and drugs and findings and signs and symptoms, all of that kind of stuff. But there's been a long relationship, not only between organizations, but by overlap of people in the SNOMED and LOINC activities. And there was a formal agreement that was created back in 2013 where there was a division of labor. And the way that worked is that LOINC had the responsibility to create all of the laboratory observables, and SNOMED basically would provide building blocks for those. So when you referred to a chemical in a test, then that would be a SNOMED concept, and it would create a linkage there. But what sort of foundational element of that relationship was that SNOMED could not create a SNOMED code that corresponded to LOINC codes. What the agreement said is that you could create a SNOMED expression, so you could create a combination of SNOMED codes that meant the same thing as the LOINC code, but you couldn't make a SNOMED code for that thing. And there was a lot of good work that was done with that in terms of mapping between parts of LOINC codes and SNOMED codes and other things. Really bright people that worked on that. But in the end, it wasn't a good solution for SNOMED people because it just didn't work sort of logistically to send a long expression where people were expecting one code. And so from the LOINC side, if you will, one of the challenges that people bring up is that LOINC is not computable in the same way. That is, it's not a formal ontology, and that people wanted a more computable representation of LOINC. And so we got together back in 2022, and we made a new agreement. And the purpose of that agreement was to make things better for the world in terms of use of SNOMED and LOINC, and to do that together. A little more context there is that in some countries of the world, regions of the world, basically by regulation or sometimes legislation, it mandates the use of SNOMED. And so essentially by the agreement, they didn't have any standard terminology. They basically made up their own. So this makes it, so that by making a new agreement that not only allowed, but was the goal to make SNOMED codes for the LOINC codes, to make so that people who could only use SNOMED codes would have valid content for laboratory and create interoperability in that way. So the benefits, again, is that we would provide then codes so that people who are using SNOMED could use those codes and use them in the way they expected, but the content would come from and be authored by LOINC and folks in the Health Data Standards group. For our part, talking now as LOINC, we wanted to be able to create a SNOMED a representation of LOINC that was computable, an ontology, if you will, that was consistent with the rest of SNOMED content. And so we wanted to do that. It's been a great collaboration, and it takes the advantage of knowledge and capabilities of people in both organizations. One of the things that was in the back of our mind as well is that this collaboration could be a precedent for how not only LOINC, but SNOMED and others could work together to create unification of information and terminology where, a single organization wasn't in charge of everything. So, in the case of SNOMED, for instance, they're not actually the best source for laboratory concepts. They're not the authoritative source for organism names or for other things. And so there's a need for collaboration that brings things together and unifies them while people maintain the knowledge and authority that they have for the area that they have. So other things that we plan to work on are, imaging, genetics, nursing information, mental health concepts, a lot of things like that could follow this same pattern. So what have we done? So again, what we did is set it up so that every LOINC code would now have a corresponding SNOMED code, and that would be defined by concepts that are part of the SNOMED ontology. And so we created 23 to 24,000, somewhere, in that range of laboratory LOINC codes that are available now for people to review and give us comments and information so that we can improve that. That is hosted and made available from the Regenstrief Health Data Standards website area. So that server and all that is available from Regenstrief. And it's at loincsnomed.org. And then there's also a browser, and I think you'll get to see some of the tools that are made available. But that, it's been great. And I just emphasize it's been a great relationship because we find out things, both sides. We found content in Loink that, things that were obsolete. They did work and found synonyms for things that kind of unrecognized synonymy. So we had some redundant concepts. Questions about, whether rough ragweed was the same thing as plain old ragweed, and all kinds of interesting trivia, but led to improvements. And it's been a really fun and good people to work with in that collaboration. So we've met together face to face at different places in Salt Lake and Montreal and London. And then we meet every 2 weeks just on a conference call to correlate work and do things. I would just emphasize, though, that this is not, we're not giving Loink away. What we're doing is making Loink available in a SNOMED representation that it makes it available to the world. But it's still owned by Regenstrief, by the Health Data Standards Group. We support it. It's distributed from the website here. And so we retain, if you will, the intellectual leadership of that whole area. So we're excited about that. So what are we doing next? Well, we're going to analyze the feedback of that we get from that preview version of the tests. Then we're going to complete and do all of the laboratory part of Loink. Then we're going to turn to and do clinical observables, all things like blood pressure and heart rate and height and weight and all those things. Then the document ontology part, and then modeling and terminology for imaging studies. So those are the things that are sort of on the agenda that we're going to work through systematically to try and complete. On the logistics side, we need to create some more formal governance around that, create an advisory group, create a way so that people from both groups, from Loink and SNOMED, that have interest in observables can talk together and do that together, rather than each organization having its own just doing its siloed work, and create an advisory committee. And then always one of the big things is finding money to support this good work. So that's another part of the logistics that we have to work on. So having said that, I want to take just a minute to also sort of wax philosophical about how all of this creation of terminology, collaborations with other organizations fits into what I see as really a vision of what we're trying to accomplish. Now, in my mind, and I think this has been common since the first meetings with Clem, et cetera, is to really be able to create plug and play interoperability. And what we mean by that, or what I mean by that, is that you've defined precisely how data should be represented in a computable way so that you can depend on it. And you can access that information through APIs and through different strategies. But what it means is that when something happens in the real world, you create a digital representation of that. And when the same thing happens, the digital representation is always the same. Right now, that's not true. you can represent it many different ways by whether you pre-coordinate codes or post-coordinate codes and do all kinds of things. But we want to create a standard, and that would be manifest basically if we got to the point where you could go to a marketplace of healthcare related data or devices or knowledge applications, and it was like buying something in the Apple App Store. You go there, you click, you can see the price, you can see ratings, you can see other stuff. But when you download it, I don't have to do configuration of my iPhone. I don't have to do terminology mappings before I can use the application. I don't have to do import, three people to do the interchange. So that's what we mean by semantic interoperability. Well, what are the implications of that? The current paradigm is that you do research, you do observational, you learn things, and then we publish them. Could be in presentations, formal journal articles, peer-reviewed activities, AMIA presentations, etc. And so then the clinicians go to those meetings or read the books or read the articles, and they try and keep that all in their head. And then when a patient comes to see them, they try and remember all of that and apply it to the case that they're seeing, to the particular patient or person that they're trying to take care of. And it doesn't work. As these two comments indicate, the complexity of modern medicine exceeds the inherent limitations of the human mind. And, Clem, one of his really early and significant publications was to note that there are limits to man's capabilities as an information processor that assure occurrence of random errors in his activities. But I mean, you can apply that in many ways that I could give you many examples. What that leads to, and another way of stating it is Dr. Larry Weed's statement, which is medicine in denial. That's the name of his book, which the whole theme of that book is, look, we've got to do things differently. We can't go forward assuming that we can teach every person everything they need to know to take perfect care of patients. But as Clem noted as well, we can't perfect a person, but we can perfect the system. We can make systems that in fact lead to the best possible care. So in my mind, we're at the same kind of pivotal point in history that occurred back in 1440 when they went from hand copying manuscripts to a printing press, going from 3 or 4 pages a day that somebody could laboriously scribe to doing 3,000 or 5,000 or 600,000 copies of an item, and it changed the world. The ability then to share knowledge, to share things that were learned, and it changed by a quantum amount. And we're in that same situation, because what I'm imagining is a situation like this where basic research and those things go on. But what happens along with publishing, which probably continue forever, but what you do is you create a program that incorporates that knowledge. So I create a program, for instance, that maybe helps me detect the number of patients that have occult sepsis in the emergency room. And I create an executable program. And if we're in that environment of plug and play interoperability, nobody has to read that knowledge to actually now make it applicable to patients. I can go and download that knowledge, and my system can be aware of the patient situation, whether the knowledge that I have is appropriate for that situation, make an appropriate recommendation about drawing blood cultures or doing whatever needs to be done. And that changes things dramatically, because what it means now is that we've got to change paradigm where we're representing knowledge now as executable programs or executable knowledge as opposed to things that are passive in a book or in an article or in somewhere else. And we ought to then give academic recognition to people who are doing that. It's a tremendous, I mean, it's really a paradigm shifting change to the culture. Because now when I learn something, I can immediately make it available to everyone. And that becomes an ever improving, changing asset of the world. And so we need to change and do that. It will be truly a paradigm changing pivotal moment if we can do that. It changes health education also, and you can think about a whole bunch of these kind of implications, but it says we've got to change medical school and nursing school and other things to not focus on memorization of facts, because the computer can hold those and understand them. But what we need are people who can communicate, people who can do physical exam, people who can manage a process and use the tools that we create, the electronic tools that we create to take care of patients. And instead of giving them tests on how much they memorized and how much they can remember, you actually test their capabilities by seeing how well they can use the information resources, how well they communicate, how well they can do physical exam, how well they can manage that process. So it creates a tremendous change. So the last thing I would say, and this comes from just participation in this activity for 30 years. We went to a LOINC meeting in Barcelona, which was wonderful. Loved Barcelona. And I went to see La Sagrada Familia, which is an amazing basilica. And after that, I got an invitation that said, we wait for you in 2026. In 2026, they're going to dedicate La Sagrada Familia. And so they're inviting everybody in the world to come to that celebration. But behind that is the point that I want to make. When we talk about this interoperability stuff, we're involved in a movement. We're involved in a campaign. And to quote Antonio Gotti, who was the architect of La Sagrada Familia, to do things first, you need love, then technique. And I would say if we advance that, would say love, then you get technology. But then what he said was, what must be always preserved is the spirit of the work. Its life will depend on the generations that transmit the spirit and bring it to life. We're not going to get it done in a year or even in 2 years or 10 years, but it is of such value and of such worth that we need to instill the love and the vision of what we're doing in the next generation and the next generation, because this celebration in 2026 will be the 100-year anniversary of the death of Antonio Gotti. So he worked on this for, I can't remember how long he lived, 50, 60, 70 years. He was killed in a tragic accident in 1926. And now 100 years later is coming the realization of that vision. And we've got to think in terms of that. I hope it doesn't take us 100 years, but it's not going to take us 2 years. And we need to inspire people about this work and what the value is. I apologize to everyone for taking more than my time. But thank you so much, and I look forward to saying hello to you. Next up, Stephen.
All right, so I'm going to him and I are briefly going to go over some of our online resources for LOINC, UCUM, and other projects. First, we would like to direct you to loinc.org, which is our main avenue for accessing anything LOINC related and resources, such as documentation for like our knowledge base, our user guides, articles. You can also contact us or our community via our forum or our contact forms, and it is the place to download LOINC. On link.org, we also have Search Link. We released it in June 2021 as a replacement for our old online link search application. It features a robust search syntax and UI to assist with searching link. The screenshots are a little small, but we also have like a filtering system similar to like an online store. So you do your base search and then you can filter it down and get closer to what you're looking for. Also on loink.org, we also have our Loink hierarchy browser, which we released in June of 2022, and it replaced the hierarchy browser that we had in Realma. It allows you to search and browse the 7 different hierarchies that we publish, which is the component by system hierarchy, which anybody who's familiar with Loink may know it as the multi-axial hierarchy. Our component hierarchy, our class, system, meth, document ontology, and panels. You can also, the searching functionality within this uses the same syntax and technology that SearchLink uses. And if you can't find what you're looking for, you can create a submission for a new term in our submission portal. So you just go to loink.org/submissions. You can request new Loink concepts. You can also view concepts to be included in the next release via our pre-release page. And you can also see our queue details, what we have. So maybe you want to make a request for something. You can check there to see if maybe we already have an open request for it. And you can also view the status of your submissions. And with that, I'm going to pass it over to Tim to go into a little bit more detail about some other resources.
Hello, everyone. I'm going to continue our discussion of some of the resources that we have available. One of the first things I want to point out to you is our Loink details pages. Detail pages are like the Wikipedia entry for every Loink code. They contain all the information about that particular code, descriptions, the axes values, the display names, the links to corresponding concepts and other terminologies, translations, related names, lots of different things. If you have a Loink code, and does everyone know what a Loink code looks like? Anyone? Some people. It's basically a series of 1 to 6 digits, and then a dash, and then a final check digit. So if you see, it's very recognizable thanks to that dash at the near the end. But if you have one, you can go directly to the details page for that concept by going to loink.org/ and then the number and the Loink code. So a couple of tidbits about Loink details pages. You can, the details pages are the most visited set of pages on our website. And one of the reasons for that is because if you go to Google and search for Loink and then whatever concept you're looking for, like Loink and systolic blood pressure, or Loink and glucose glucose in blood via a test strip, or Loink and PHQ-9, you'll get a rudimentary set of results that have links to all the different details pages. It's definitely not as thorough and as detailed as SearchLink, but gives you a good sense of all the Loink codes that are out there. In fact, if you search for just the code without any text corresponding to that, you often get a link directly to the details page for that code right after the multiplication, or sorry, the subtraction of those numbers. So it's always fascinating to me how highly we rank, and it gives you an idea of how good our Google juice is on our Loink website. And then switching gears, we produce this Loink terminology service, which uses HL7 Fire. And you probably, through attending many of these presentations, know that fire is a hot topic, no pun intended. Loink and UCOM are very much baked into HL7's standard for health data exchange. We have this terminology service, and it's a reference implementation from which users can get Loink content programmatically. It exists as a beta, and it supports these 4 resource types that we have listed here. Additionally, we have enabled versioning of code system, value set, and concept map resources, so you can refer back to previous LOINC versions. We have also added translations. We have a wide, one thing we hadn't really mentioned is the number of translations we have in different languages, but those are available through our FHIR server as well. You can find detailed information on how to use this terminology service at loinc.org/FHIR. And one of the things, as you know, on the topic of FHIR, is that this is something I think pertains to everyone. And it's probably something you don't realize it actually exists. If you have, as a consumer, if you use the Apple Health app, you can connect to your provider directly to get all your health data information on your phone. And the way that it connects to your provider is through FHIR. And if you go now and you have all that information on your phone, this gives you an example of a sample user. You can see there this is a cholesterol test that this individual had done. And if you click on that HDL cholesterol, you'll get to a second screen, which actually lists the LOINC code and the word LOINC, which corresponds to that test that was performed. And if you click even further and go to the source data, you can actually see the source, the underlying JSON that was used to represent that observation. And it actually calls out the LOINC code as well as the UCOM, which is used for the units for that observation. So I always thought that is really cool, and it pertains to everyone. And again, this is a consumer application, not something used by physicians. This is actually available to all of us as consumers to see our medical records. And then speaking of UCOM, we do have a UCOM website. UCOM was kind of in an unmaintained state for a few years, but it's now back under our control. We do have this website at ucom.org. The site will also take you to our GitHub repository, which is where we're actually doing all of our development. And I just wanted to note that we are doing some reorganization, and you can expect a new release of UCOM later this year. And then finally, I wanted to reiterate some of the things that Stan had mentioned in regard to the work with SNOMED. We have this standalone website because it is a joint effort between the two organizations. We have the standalone website at loinc.snomed.org, and it is a site that we develop here at Regenstrief to provide a face to this collaboration, and it does provide a number of services, including ability to download the ontology as well as provide feedback, and you can actually browse the ontology directly by clicking that big blue button. And then I think that's all I needed to discuss in terms of resources. I'll hand it off now to Dr. Isa Hafiza. She's going to talk about some HDS initiatives.
Hello, everyone. I am here to help you out materialize and show the presence of LOINC in all the projects that we are involved in. So I'm gonna give you some few topics so that you will see where LOINC is used or where it is that what project that we are involved in that we are working on to materialize that work. As you see, there are a list of topics that we can go through. For example, in the post-acute care, the MDS or minimum data set by CMS, the health data standards team is working with CMS to assign some LOINC code to CMS PAC assessment data elements and other ones, like, for example, the OASIS for home health outcome assessment information set and the nursing home minimum data set MDS. In the equity, we have been involved with the HL7 on the Gender Harmony project. In this project, what we are doing is assigning LOINC in sex for clinical use, which is category that is used to indicate some specific clinical observation and where it's particularly those that are impacted by the sex-associated conditions. Other topic that we are involved in right now is the public health. In public health, it is working with HELIOS. HELIOS is an HL7 project. It is supported jointly by CMS and ONC to use widely recognized data exchange standards to help advance public health by using HL7 FIRE. REILS requests to use long codes in defining public health measures for situational awareness. Eye care, the National Eye Institute by NIH has asked Health Data Standards team to create a long code for visual acuity quality measures data elements. So this is something we are embarking on right now. In outcome measures, we have been always working with the NCQA on the HEDIS, but now we have been asked to create a long code for goal attainment scaling, GAS, which is a scale that assesses the extent to which a patient is achieving a health goal. It's a method of scoring that extent to which patient individual goals are achieved in the course of an intervention. We also work with the provider and payer processes, PIE, where we are always responding and maintaining the HIPAA value sets in HL7 FIRE standards. SDOH, as you have heard previously from Marjorie, the project that we have been embarking on with the Gravity Project, it is worth mentioning one that is very prominent, which is the American Community Survey Consensus, which is the premier source for information about America's changing population, housing, and workforce. This is a very much important nationwide survey that collects and produces information about the nation population. And actually, the survey from that, on it depend the donation that's given to each state based on the change in this population. Molecular genetics, nationally and internationally, this is a subject that's evolving. That's the activity on effort is very high. It is worth mentioning, for example, NICTIS, which is the National Competence Center for Standardization and E-Health in the Netherlands. They are fully using Loin code to the point that the laboratory communities there are supported with their adoption of Loin. I need to add also the BITAC or IQVIA in Spain, who is requesting Loin work from the health data standards team to support their molecular genetics laboratory compendium that's expanding very fast with the need. Population health studies, we have been involved for the last 2 or 3 years with the Charité Medical School in Berlin, with the Orchestra Project, because they are doing studies on the psychological and psychosocial effect of the COVID-19 on their population. So this is something where it is very highly needed. Not to forget also the project for livid lung in vitro diagnostics, supported by the CDC and FDA to provide Loin code to all the manufacturer diagnostic tests and kits. This is also, I would like to also mention one word about the UCAM work that is across all these topics, because these are units and we are working on maintaining or creating new units with the help of the advisors of the UCAM community. Thank you so much for your attention. And Marjorie, would you like to hear some questions? Sure.
Thank you, everyone. As I mentioned at the top of the hour, we had a lot to present. We just felt that we wanted to give you a deeper dive into who we are and what we do. We hope we accomplished that today. I don't know if we have 2 minutes. If there are questions, how are we handling that? Come to the mic, or I don't know if this ask online. And am I checking the online? Is somebody else doing that? Oh, okay. Beth is doing that. But also, I'll say if there are no questions, please feel free to reach out to all of us. We are your colleagues, and we are happy to answer any questions if you have them. Okay. All right. I don't think we have any questions here. But thank you, everyone, for coming.